Hi there, everyone. I think it's time for us to get started. I'm very happy to welcome you all here and introduce Michelle Loftwell to describe our new Marion Fischman Award. And I can't help but just say that Marion was a beloved mentor of mine. So this is a very meaningful award. She is a tremendous person to follow in the footsteps of. So welcome, and here's Dr. Loftwell.
It's my pleasure to just say a couple of things about Dr. Andre Jones for this award that is in honor of Marion Fischman, who's described as not only a leader in substance abuse research and an outstanding scientist, but also as a wise, loving, and brave human being. And I can't help but think that those adjectives also apply to Andre. And one of the reasons why I wanted to nominate her, because her work is seminal. It's in the field of taking care of women and their children and children themselves. And she always says yes. So if you ask Andre for help, if you ask her whatever that help may be, even if it's in a field that isn't exactly her own, as one of her mentees, Meg Chisholm, said, that helped mentor her over the years and was such an important contributor to her own career. And so many others, Andre says yes. And she doesn't say, like, okay, it's a resounding yes. So we all know Andre because of her work with the Mother trial, which was a seminal piece of work that's still cited today and was a huge influence on the UNODC guidelines for substance use. Her work is also in Southeast Asia under the Colombo Plan, and I think we'll probably hear some more about that. And also, her nomination letters came from several other people, including Dr. Bob Balster, who says, Andre's had tremendous contributions to drug abuse research and is one of the foremost experts on perinatal addiction in the world. Dr. Sarah Heil, again, tremendous contributions, and more importantly, compassionate. Always her research is about compassionate treatment of pregnant and postpartum women with opiate use disorder, as well as their children. And with that, I'm going to let Andre have the rest of the time, because she's much more interesting to hear from.
You know I'm short. I have literally no adequate words with what this means to me. I am so honored by the awards committee, by the CPDD leadership, by the family that was Miriam's family. So this award has been incredibly meaningful to me. Thank you to Bob Balster, who is a lifelong mentor, to Michelle, to Sarah, to Meg, for their constant support. And very importantly, to my family that's in the audience today, my mom, my dad, my family friends, Dell and Jan, for their steadfast support. And my family, my children, my daughter, Ashley, and my son, Davis, and my husband, Eric, are actually in the Dominican Republic right now, so it's being live cast. Because we didn't know this was going to happen when we created this really great vacation. So they're in the best place ever. So thank you so much for all of their sacrifices to help me bring you what I'm going to share with you today. So if you notice the slide on the top, you might notice some familiar faces. These are the 4 Hendrys. So I'm actually the 8th Hendry, but they stuck an accent on it and called me Andre because my dad didn't want 2 Hendrys in the same house. So these are 4, and I titled this talk "Walking in the Wisdom of Women" because these 4 women have had a tremendous influence on how I see life and how I see empowerment for women. I could not do this talk without extreme gratitude for Miriam. I only had the opportunity to meet her once when I was a postdoctoral fellow at the BPRU, but I will never forget meeting her because she had this radiating presence and poise and was so wise. And I remember looking at her and thinking, I hope one day I could be half as amazing as she is. To all of the amazing awardees that have come before me, I've listed you here, and I am indebted and feel like I have to fill big shoes for this award. So thank you for your wisdom to help bring me to this place. I also walk in the wisdom of an amazing community of women scientists. As you can see here, we have Loretta Finnegan, who is our pioneer of perinatal substance use disorders in the field. Carol Kaltenbach, who has been also a lifelong mentor, and we've gone all over the world together. We have Dasi Svikas, Lauren Jansen, and Marta Velez, who really taught me how to work with women and how to listen to women. Coralie Weatherington, who's been a steadfast supporter of all of the work that we've done with women. Sharon Walsh, I love this picture of you. You look so happy. Thank you for all of the many late night conversations. Max, you're dancing. You will always forever be dancing in my heart. So thank you for your mentorship. And then my sisters of science, Meg Chisholm, Sarah Heil, and Michelle Lofwell, for all of your support and collegiality. I also want to enjoy walking in the wisdom of recovery sheroes. And these are the women that I have learned so much from. They are the women that live treatment and live recovery and hold the hope for others that recovery is real and it is possible and it's lived every day. And they've taught me more about addiction than anybody else. And I would be remiss if I didn't include the men, right? So it's a full sky out there. So I've got to walk in the wisdom of women with some really awesome male colleagues. Bob Balster, who's been that lifelong mentor, who picked me up at VCU and had hope for me. Ed Johnson, who taught me how to do clinical trials with Eric Strain, George Bigelow, and Roland, who taught me how to do inpatient laboratory studies to really ask those precise questions with humans that I'd only done with rats. For Kevin O'Grady, who's the unsung hero and the statistician that's been with me for over 20 years. For Ken Stoller, and Ken Stoller, the other Ken Silverman, and Mishka, who have been just amazing advocates. Ken Stoller and Mishka have been my sort of brothers in arms in advocacy work, and Ken Silverman taught me so much about contingency management. So thought I'd take this talk, because I've done a bunch of different things, and I was wondering, how in the world am I going to draw a theme? And Bob used to tell me, Andre, you got to draw a theme in just make it up, but you got to have a singular theme in your work. So I've kind of made it up. So here you go. It's been a long and winding road to get here. So I started in Richmond, Virginia. And so when I was in Richmond, what happened to my, hello, okay. So when I was in Richmond, I went to Randolph-Macon College for undergraduate, and I got to meet Kelly Lambert, who was a pioneering woman who has multiple papers published in Science about maternal behaviors with rodents. And she taught me so many different things, in addition to Craig Kinsley at the University of Richmond. And what I learned in the animal lab, I got to apply in the human context. And I learned 3 really important lessons. One is that we need to have precise language to pay attention. What are those very particular words that have very specific meaning? Second, I learned to ask very specific questions. So what is it we're really trying to answer? A lot of times sometimes I think we think about studies in terms of papers, when we need to be asking, what are the questions that need to be answered? And I got to do that in the animal lab. And then finally, the third and probably the most important thing is that words are softer and more quiet than behavior. And so we need to listen to the behavior and not so much the words. And I certainly learned that with the patients that we have. And when your little rats can't talk, all you can do is focus on their behavior. So when I went to the Virginia Commonwealth University under the mentorship of Bob Balster, I had the opportunity to work with Scott Bowen. Sorry, Scott, I don't have a picture. And we started looking at prenatal exposure to abused inhalants. And here's how it went. And those of you who know Bob, this is quite telling. So I am working in the rat lab doing this drug discrimination studies, and he comes in one day and he says, hey, Andre, I have this paper about fetal solvent syndrome. You know something about development. I know something about solvents. Read this and tell me what you think. So I read the paper, and it was 15 cases of women living in a Native American community context, and they all had babies that had fetal solvent syndrome they'd been abusing solvents, and it was all the different effects were attributed to the women huffing glue or paint or gasoline during pregnancy. And so then I went through the literature and I looked to see if there was an animal model. And the only animal model that was out there was of environmental exposure, so long-term, low-level exposures over periods of days. And so I went back to Bob and I said, I think I have an idea. What if we developed an abuse paradigm where we gave the little mice high amounts of abused substance like toluene or TCE over short periods of time throughout gestation? And he's like, that sounds good. Write it up. Give me an IRB proposal. So I did. And so then we did several experiments, one that you can actually see here, which is the developmental consequences of that intermittent as well as continuous exposure to TCE. And we found some really interesting behavioral effects. So we didn't see physical effects, but we saw changes in like the writing reflex and in the negative geotaxis. And that ended up creating and forming the basis of my dissertation. And actually that work is still carried on today in different labs. So really being able to better understand prenatal exposure to abused solvents. So while I was there, I had a really hard time killing animals. I loved my little mice. We got to spending 20 hours sometimes a day in the lab. We got to know each other pretty well. So I felt kind of bad when I had to euthanize them. And Sid Schnoll and Debbie Haller happened to have a perinatal 20 program down the street. And so Bob says, hey, Andre, go give a talk to them and see what they think about your work. So I did, and Debbie and Sid introduced me to the most amazing program that I ever knew could exist. It was a perinatal 20 program for pregnant women who had a cocaine use disorder and their children. And it was a comprehensive program, and you could live, there was a piece of living there. And so that's the study that is shown there, looking just at retention. And so I really fell in love with the patient population. And when I talk about walking in the wisdom of women, I will never forget my very first day co-facilitating a drug education group. And so that drug education group, I have studied for like 2 weeks. I had all my notes. I was ready to go. I could tell you every acute effect, long-term effect, withdrawal, you name it, I knew it, like a textbook inside and out. And so I go in and I say hello and we get names and I start writing on the whiteboard and I turn around and everybody's like, this. And one brave woman said, girl, you don't know what you're talking about, do you? And I had deer in the headlights, and I'm like, what do I do? What do I do? Listen. And so I did. I put down my notes, and I said, yeah, you're right. I don't. Why don't you tell me? And that was the best thing I ever did, because I learned more about addiction from the patients than I ever knew in any textbook. And so that kind of set my stage. So then I told Bob, I was like, I really want to do human work. And he said, if I got the perfect person for you, Dossie Sfikis has this most amazing program at Johns Hopkins University. Why don't you call her up? And so we did, and we had this amazing 2-hour conversation where she told me all about the Center for Addiction and Pregnancy. This comprehensive program has childcare, has OB, has psychiatry, has groups, has transportation. And I thought I had died and gone to nirvana. And so I went and I applied for a postdoc at the BPRU, and Roland picks me up. And I didn't get to see Dossie the whole day. And I got to meet some amazing folks from the BPRU, and they offered me a postdoctoral fellowship. And then I got to meet Dossie, and we had great collaborations, a very failed one looking at prenatal exposure to caffeine. That is another story for another day. But we got to start to collaborate. And so I have great admiration for Maxine, for Roland, for George, for Eric, for Ken, for Ed, Dossie, Sharon, and Ken. And you can see there's Marta. We call her the baby whisperer, and she taught me so much about how to do the ends and how to work with babies and how to listen to babies. And then there's Lauren, who taught me all about the children and the potential long-term effects that could be there that could be mediated or mitigated by the post-environmental aspects. And so I was working on my postdoc. I had 18 papers coming out of that postdoctoral fellowship. And then Dossie got 2 grants funded, and she offered me my first faculty position, for which I will forever be grateful. I learned so much from her. And during that time at the Center for Addiction and Pregnancy, we did all sorts of amazing papers. This was a really, really fun time to do science, because there wasn't that much that was known. We had the pioneering work of Carol and Loretta and some work by Beth Reed and Normal Finkelstein, but there was still like a lot of uncharted territory. laboratory. And so we did studies where we looked at homelessness versus non-homelessness to see were there different outcomes if you just categorized women in the Center for Addiction and Pregnancy who were pregnant and had substance use disorders, and we found, not surprisingly, that the homeless group looked worse, right? So then we thought, what could we do to help intervene and help get housing? We identified all sorts of different subcharacteristics. We looked at the role of PTSD on treatment outcomes. We looked at the role of depression on treatment outcomes, not just for the mom, but for the babies too. And then we did really interesting, innovative intervention work. And I don't know if Babita Das is in here. She was probably my third research assistant. There she is in the back, and there's Dossie here. And so Babita and I were just talking this morning, and she said, oh my gosh, Andre, do you remember when? I used to have urine collection bags in the back of my trunk, and I drive into inner city Baltimore, and we'd take urine from women who were in part of this brief intervention study. So we did a lot of crazy stuff. And we got a lot of really amazing results, because what we were able to show was that case management with brief intervention can actually produce better outcomes than sort of no treatment or mild treatment alone. And probably one of my favorite studies at the Center for Addiction and Pregnancy was actually a retrospective study that looked at women that were receiving methadone. And what we noticed clinically, that women that were heavier smokers tended to have babies that had worse NAS. The babies stayed in treatment for needed treatment for a longer period of time, stayed in the hospital for a longer period of time. And so it was Robin Chu that led that investigation where we actually saw that, which has since been replicated many, many times today. And so as we were going forward, we wanted to get more and more practical in our research. What could we do to really, truly make a difference in the lives of women that we were studying? And so thanks to Max, who came up with the reinforcement-based treatment in non-pregnant individuals, we were then able to apply that to pregnant individuals, because CAP was doing a really good job with women that were treated with methadone, but we weren't doing such a good job with women who were treated for cocaine use disorder. And so we had this study where we brought women into the Center for Addiction and Pregnancy. They all had a primary cocaine use disorder. And then we had 50 women in the usual care and 54 in the reinforcement-based treatment condition. And we gave them a package. So it was basically CAP usual care versus this enhanced package of treatment, which included individual counseling, specific job skills, and of great importance, abstinent contingent housing. So as long as the women were testing drug negative, they could get free housing. And so with this study, we really showed how important it was for women to have that free housing, that they could do much better in treatment in terms of just being retained in treatment, which is important for them being able to have prenatal care, that case management, all those other aspects, access to the birth clinic, things like that. And then we also, not only did we have mom outcomes, we also had baby outcomes that were positive. So we were able to show that significantly the RBT group had more days in drug-free housing. They had increased employment rates because we were providing specific help with employment. And for the children, while the means between the two conditions were very similar for gestational age, birth weight, and length, as well as head circumference, at least in terms of the babies and the length of stay in the neonatal intensive care unit was significantly shorter for the RBT group. So as we were doing this work, in addition to, I'm also still listening to the wisdom of women, I have a top 5 or 6 list about my favorite reasons why someone's urine would come back drug positive. Number 1, my boyfriend used drugs right before we had sex. It must have transmitted somehow, right? I had a dream about using, but I know I didn't. I was at a party and somebody blew smoke in my face. You know how it goes. Well, I was helping somebody move a load of crack. I really didn't have any choice but doing that, and it got on my hands, and that's how my urine is drug positive. And finally, my very personal favorite is, oh my gosh, I must have eaten too many poppy seed bagels. So we decided to test this one day in our little research unit. Anybody know how many bagels it takes to test positive? We determined 3, so just so you know. So as we were also continuing to work on the behavioral aspects of care and what we could do to help improve outcomes for women, I remember sitting with a woman who was about 90 pounds. She was on about well over 100 milligrams of methadone each day, and she was still continuing to inject heroin. And I remember sitting with her because she needed to go in front of treatment team, and she was really scared, so I was giving her some support. And so I turned to her and I asked her, I said, tell me a little bit about what's going on with your injection drug use. And she looked at me and she said, Andre, I don't even feel the heroin. I don't need to inject. I don't feel it. But my boyfriend won't inject alone. And so that to me was really a powerful thing. And so it made me start to think about, we tell people to break up with people, places, and things. And what I realized was the women were much more likely to break up with treatment before they were willing to break up with their boyfriends who have tremendous power over them. So we did a little retrospective study to see if we could show this sort of clinical hunch. And so these are the data from that retrospective investigation where we just categorized women by drug-free or drug-using partners, and we were able to show that retention in treatment was significantly greater when women reported having drug-free partners than when they reported having drug-using partners. And so I thought, wow, what could we do if we took the opposite approach? And rather than telling women, break up with treatment, what if we said, hey, come on in, partner, we want to tell you about treatment. Let's make it not so scary, and let's offer them treatment. Would that make a difference? And so I'll never forget the first week that we started this study, because the research assistant came into my office and she shut the door and she's like, Andre, you have to make it stop. And I'm like, what? What are you talking about? She's like, all day long, my boyfriend wants free treatment. So she was getting her door just knocked down. So we knew we were onto something good. And so these are the data from our very first initial feasibility study, where we were able to show that we could, if we paid for it, we could get a significant proportion of those partners into treatment versus if we just had control, which is basically like, here's the resource list of treatment, good luck. And so that led to a two-group randomized design that was my very first RO1, where we had a control, which was that the male partners could come in for a weekly support group, or the male partners could get this whole package of services that included free methadone or free withdrawal, if medication-assisted withdrawal, if that's what they wanted, weekly support group, individual counseling, and then drug abstinent contingency management. And this is what we found. So our partners had significantly greater negative opiate positive urines at 3 months, for an example. They also were able to more positively support the woman. So she had a greater perception of perceived social support, which is really important in terms of outcomes. So we were able to increase the woman's retention and treatment. We were able to decrease her drug use. We were able to increase her involvement in recreational activities. She ended up having less reliance on public assistance and had that feelings of increased social support. So those are some examples of the behavioral studies that we've done that are kind of my personal favorites. Now let me talk about what's probably dominated most of my career and what's in the field is the issue around methadone and buprenorphine. So when I came into the field, I remember sitting with Ed Johnson, and he's like, look at this. And he showed me the structure of buprenorphine, and he's like, do you know what it was? And I said, do you know what it is? And I said, no, I don't. I'm a postdoc. I've worked in sort of the cocaine field, and I don't know what that is. And so he talked about buprenorphine. And at the time, there were the first 3 women ever in the United States that were receiving buprenorphine at the Center for Addiction and Pregnancy, where they had to live for many months. And I really fell in love with the idea of having a medication that might be an addition to methadone. So we knew that we had methadone. It had many, many decades of excellent results within the context of prenatal care and other aspects of care. And there was a concern around, once babies were born, how extensive was their neonatal abstinence syndrome, known as their withdrawal. And so the folks at the BPRU were really interested in buprenorphine because if you spontaneously stopped buprenorphine in an adult, it appeared that there was a less severe withdrawal syndrome. And so the idea was, if that was true for adults, perhaps that would also be true for babies when they're abruptly withdrawn from the medication after delivery, when the umbilical cord is cut. And so that set a whole host of research studies, only a few I will share with you today. But I love to put things in important context. And so thank you to Loretta for sharing this beautiful picture with me. So this is Loretta, who is the founder of the neonatal abstinence syndrome work in the perinatal substance use disorder field. And so it's been an issue for many years in terms of what to do with women after they've delivered their baby. If they've been using an opiate agonist during pregnancy, what happens to the baby and what's the best way to manage them? And so unfortunately in the 1800s, we had some pretty awful things that happened, and babies would die because people didn't know what to do. And then in the 1950s, we had a whole host of different medications that were used to try and treat neonatal abstinence syndrome, this withdrawal. And in 1974, NIDA was one of the first missions of NIDA was really to understand better how to treat moms who had opioid use disorder and their infants. And it was from that Loretta got her very first grant to do this. And so we had the Finnegan scale that thanks to that wonderful work that is still the most popular scale today. And so that little baby that's there, so you can see Loretta looking really happy holding this baby. And I thought when I looked at that picture, oh my God, that could be me. Because it was about that 1970-ish. So that's me below. So in case you're not familiar with neonatal abstinence syndrome, here is the definition. It's a constellation of signs and symptoms that describe withdrawal. So sometimes you can have high-pitched crying. Sometimes you can have irritability, which is different from crying. So it's you might turn on the light and the baby's face grimaces. That could be a sign of irritability. Having exaggerated reflexes, looking like this. And most importantly, that sort of trouble eating and sleeping and being consoled. The idea that there's an autonomic system disturbance that's going on with yawning and sneezing. Gastrointestinal, which is, again, that poor feeding, sometimes loose stools, sometimes vomiting. And then, on occasion, signs of respiratory distress. So what's really important about this, because there's been so much media attention on neonatal abstinence syndrome, is first and foremost that it is not fetal alcohol syndrome. Alcohol has gotten completely underappreciated in terms of its long-term detrimental effects. We actually have women that come to Horizons, and I'll talk about that in a minute, that said that they stopped using their opiate and started using alcohol because they thought that that was a safer alternative. So we really need to do a better job as a research field to make sure that we're getting that accurate information out there, which is the exposure of the fetus to alcohol is the drug that we know the most about in terms of direct long-term deleterious consequences. The second thing that's really important to know about neonatal abstinence syndrome is that babies are not addicted. So if you've ever used that term, please wipe it away from your vocabulary. Babies can be born dependent on a substance. They can be born in withdrawal from a substance, but they cannot, by definition, be born addicted because they don't meet that definition. They don't have enough life course to be able to have continued using substances in spite of negative consequences. NAS, every piece of data that we have shows that it is treatable. We have good tools to identify it and assess it, and we have good medications and tools, non-pharmacological tools, to treat it. And what's really important is it's the interaction between moms and babies that can either set them on the right course, on a really positive, nurturing course, or on a much more slippery course. And so we have to do a better job supporting both mothers and children so that we can help promote resiliency and decrease risk among the children. So these are it's always funny when you put 5 years of blood, sweat, and tears onto one slide, right? So the PROMISE study was, I thought at the time, the hardest study I'd ever done. And so this was the first double-blind randomized controlled trial of comparing methadone and buprenorphine during pregnancy. And so you can see there the N's pretty small. We had 11 methadone-maintained women, and we had 10 buprenorphines, and we had one twin set, which we learned the hard way never to do that again. But my statistician, I thought, was going to have a conniption, but he was Kevin, and he lived with us. So these are the data that you can see under this small trial. We could see that we had significantly, would look like a significantly smaller proportion of babies that were treated for NAS in the buprenorphine group, but it wasn't statistically significant, but it was sort of in the right direction. The only statistically significant thing that we had come out of this trial was that there was a shorter length of stay for the babies that was 6.8 days versus 8.1 days in favor of buprenorphine. And so what that did, the other thing that it did, is we didn't have bad negative outcomes for mother or for child. So that gave us great reassurance in combination with Gabrielle Fischer's data in Vienna that we were ready to do a multi-center trial. And so we launched, and there's the mother study group right there in the middle. And we had 8 sites, 7 sites recruited. Canada did not recruit. So we had 6 sites in the United States and 1 site in Vienna, Austria. And you can see the design here with the initial consent, the screening. We had to have an IND to do this study. There were absolutely no take-home medication doses in this study, where now we've got much more flexibility, obviously. And the only form of buprenorphine we had was Subutex. We didn't have Suboxone yet. So and that didn't come on until we were well in with during the study, because that's one of the questions I get is, why didn't you use the combo product? We didn't have it, so we couldn't. And so we randomized the women into the buprenorphine or the methadone group, and we followed them. We asked them all sorts of different questions, very carefully studied them until 28 days post-delivery, and then a sub-study that did the long-term follow-up. And so here you can see the hardest study I've ever had to do with the mother results all on one slide. And so here you can see that the proportions of babies that required treatment for neonatal abstinence syndrome was not statistically significantly different. If you look at the non-blinded trials, often typically you see significant differences just in the proportions of babies, but under double-blinded conditions, we didn't. The peak score was also not statistically significantly different. What was statistically significantly different was the amount of morphine that it took to treat those babies that were prenatally exposed to methadone versus buprenorphine. And then subsequently, the length of hospital stay was also significantly shorter in favor of the buprenorphine. Head circumference was not different. So we found that it required 89% less morphine to treat the buprenorphine-exposed babies compared to methadone. Babies spent 43% less time in the hospital and 58% less time being medicated. But what's most important of this whole study is that now we had randomized controlled trial data for 2 medications. It was the first real study that showed conclusively methadone had relative safety and efficacy during pregnancy. And so for some, like FDA and regulators, that was really important. And it also showed that we had an alternative. So now rather than 1 medication, we had 2 medications, so women could actually really have a choice of what they wanted. When we know the contextual difficulties, but if both are available, you have an option to have both. So that we learned so many things from this sample, and I will forever be grateful to the patients and the women and our collaborators for doing all that they did to make this happen. Marilyn Hustis has been one of the previous awardees, and I know has talked about some of this data, but we learned through the PROMISE study a tremendous amount about the pharmacokinetics and the dosing of buprenorphine during pregnancy as well as methadone. We had papers on the fetal effects. We were able to show that there were differences in how fetuses responded to steady state methadone or buprenorphine. We were able to develop pain management protocols that are still used today and how best to address both prenatal, like labor and delivery pain, as well as postpartum pain. We were able to look at the obstetrical and neonatal complications and show that when women are well treated in a comprehensive care setting, they actually have relatively few problems, as do their babies. We were able to look at the liver enzymes and the hepatitis C because there was concerns in the literature about high doses of buprenorphine and hepatitis C complications. We were able to look at breastfeeding and once again say without reservation, if women are taking methadone or buprenorphine, it is compatible with breastfeeding. There's such a tiny amount of medication that gets into the breast milk with methadone or with buprenorphine, and considering how small the bioavailability is, oral bioavailability is of buprenorphine, that we need to be encouraging that skin-to-skin contact. That's what's best for mom, and that's what's best for baby. We were able to look at neonatal abstinence syndrome predictors. We showed again, and now in a prospective study, that the more cigarettes women smoke during pregnancy, that the greater the NAS severity will be. and it didn't matter if it was methadone or buprenorphine exposure. And then we also consistently showed a lack of NAS severity to dosing. So there's, the literature is sometimes mixed around if you give more methadone or more buprenorphine, then the baby's NAS severity tends to be worse. When we showed in this controlled study that that was not the case, there was not a statistically significant relationship. And we still have manuscripts out there. Every time I think I've asked the very last question for the mother data, somebody invariably comes up to me and is like, hey, is that data still available? I have another question. So if anybody wants that data, it's still publicly available, and we're happy to have you look at it. I think the second landmark study came out with Carol Kaltenbach as first author, and this was her baby, which was looking at the long-term outcomes of prenatal exposure to methadone or to buprenorphine. We had 96 children that participated in this sub-study, and we looked at this data every which way we could think to look at it. We looked to see if there was a relationship between methadone and buprenorphine, and there were no differences. We looked at them we looked at the behavioral, physical, cognitive outcomes compared to a normative sample. There were no differences that we could find. We looked to see if there was a difference being treated for NAS versus not being treated for NAS. There were no differences that we found there. So we found that in this double-blind trial, where the people that were evaluating the children didn't know what the child's status was in terms of prenatal methadone or buprenorphine exposure, which I think is incredibly important for those long-term studies that we're doing, is to have blinded evaluation. We found that those children up to 36 months were following a very normal developmental path, which I think is reassuring for those moms and providers out there providing the medication. These results collectively taken together started to serve as the foundation for guidelines changes and guidelines creation. So I think it was in about 2010 where CPDD was the birthplace of an international forum where everybody that we could think of who was doing prenatal substance use disorder work got together, and we tried to do a worldwide consensus. So we emailed out this document to everybody we could think about that was doing this work to see where the agreement was that could serve as guidelines and where there was differences that we really had to think through, or maybe those shouldn't be part of the guidelines. And so from that little one foundation that got published in the Journal of Global Drug Policy and Practice, then that set the stage for the World Health Organization to consider creating guidelines, and these are the first guidelines in the world for how to treat substance use and use disorders during pregnancy. And those were published in 2014. The United Nations also took a look at their standards, so that there's now chapters in their standards that also talk about prenatal, how to care for women who have substance use disorder during pregnancy and the postpartum period, and their children. And then SAMHSA in 2018 published guidelines, again, with much of the research that we and others have done. And so these guidelines were the very first guidelines that SAMHSA put together that were dyadic guidelines. So what that means is that they weren't just guidelines separating moms from babies, it's about moms and babies. And these are the 5 recommendations that came out of those SAMHSA guidelines. And if you haven't seen them, they're very user-friendly. They've got 16 different fact sheets that you can just print off. You can give them to your patients, you can give them to providers, you can give them to colleagues. And so the 5 recommendations that we had was that we should not be detoxing women during pregnancy. We have good medications, we have a good standard of care, and when you detox women during pregnancy, you risk relapse. You risk an opportunity for overdose that could be fatal. And they drop out of treatment. So then now they're not getting the benefit of all the other aspects that treatment can entail. The second important piece of the guideline was that methadone and buprenorphine are the safest medications for managing opioid use disorder, the same guideline that the WHO had in 2014. Third, and incredibly important, is transitioning methadone to buprenorphine or buprenorphine to methadone is not recommended. And I will never forget the first week the mother study came out and I got a call from a very large public insurance company, and they basically said, we read your data, and now we want to transition every single methadone-maintained woman to buprenorphine. Tell us how to do it. And I about had a heart attack. And I was like, no, please don't do that. Bad idea. Let's talk about this, right? So it shows you that data have power, and it also shows we have to be incredibly careful what that message is around those outcomes. The fourth one is that breastfeeding is recommended for women who are stabilized on methadone or buprenorphine. And finally, that neonatal abstinence syndrome shouldn't be treated with diluted tincture of opium, and that's because of the alcohol content in it. So now I'm going to move in my career path to Chapel Hill. I now have 2 children. And the place I wanted to start there is that we've known what to do and how to care for pregnant women that have substance use disorders really since the beginning of the Mater program in Philadelphia. And much of that was published in the second tip that was ever published in 1993. We have a model of care. We know what to do. Oftentimes, people don't want to adequately fund that model of care because it is a challenge to put together and to maintain. So when I got to Chapel Hill, I'm going to talk about the international research separately. So after a very wonderful opportunity at RTI that I'll talk about in a moment, I was offered the opportunity to oversee the UNC Horizons program. And so it was really like going home. It was going back to something that was like the Center for Addiction and Pregnancy. It was a comprehensive model of care where we had women, about 266 women, get treated every year with their children. It's a trauma-informed program. We have child care as well, a 5-star licensed child care where every single child gets screened, assessed, and services delivered on site if they need PT, OT, speech, language, hearing, other types of therapies. We have transportation provided to and from the program. We have a whole jobs component where we help women figure out what they want to do, if they want to go back to school. 77% of our women, so somewhere between 70 or 77% of our women get employment every year when they complete our program. We have housing, a housing component with a long-term residential care facility, legal aid, parenting education, which I think is the most important part of our program because we teach moms the tools that they never learned growing up. We teach what nurturing parenting is. Many of our women don't know how to change a diaper even though they've had 3 children. So we start from the basics and we just tell everybody, we're going to assume you know nothing because we don't know what you know, and we're going to teach you everything that we know so that you can be the best parent that you can be. We have psychiatry that provides our buprenorphine. We have an OBGYN clinic right there on site. And we provide buprenorphine as our main modality of medication treatment. And we have a uniform philosophy of care that is founded in part on empowerment theory. So what do our outcomes look like? It's an expensive model. I can tell you that women that complete our program, 95% of them every single year get to keep their children. That's amazing if you think about the cost of foster care, cost of loss of other different issues into the system. These are our birth outcomes that we have every year. We have about 51 babies that are born into our program. We traditionally have about 5% prematurity and 5% low birth weight, which if you look at the untreated population here, 24 or 27% respectively, that's a pretty dramatic decrease. And that's actually, our outcomes are better than the North Carolina state average, which runs about 12% prematurity and 9% low birth weight. So clearly we're doing something right. And it's really important if you are a scientist and have any interest in policy, and I didn't go into this career wanting to go into education for public policymakers, but I kind of got forced into it. And so I know that money talks, and so our program is expensive. Our program is a little over $3 million a year, but we have done cost calculations and we can save the state a little over $3 million a year. And that's just the cost calculations that we've done. We also have used our research in 2 very important ways in the state of North Carolina. One was there was a Senate Bill 297, where North Carolina was poised to be the next state, like Tennessee, to criminalize substance use only during pregnancy. And so we worked very hard and we wrote white papers, and we talked to our policymakers and educated them on what would happen if they went through with this model, and if they didn't, here's some things that they could do. And we were very successful in getting that bill to die. And then most recently, in fact, on Monday, I got the phone call that the second bill, where the state specifically wanted the option to terminate parental rights within 7 days of a woman delivering a baby that tested positive for substances, was moving through our legislature. And we were able, again, to write a white paper with using our data to be able to get that bill to quietly go away. So I think, again, it's knowing not only the power of the data, but also how to talk about the data so that people can understand it. So being at Horizons, I had the beautiful joy of having so many Humphrey Fellows and having different people, Fulbright scholars, all come and want to find out about Horizons. And so I put all these little H's there because they're little pieces of Horizons that are now operating all over the world. And it's been adapted for their own cultural context. And where did I learn how to do that? I learned how to do that at RTI under the mentorship of Gary Zarkin, Bill Zuhl, Wendy Wexberg, and Jennifer Lorvik. And so I'm very indebted to them for teaching me how to do international research, for teaching me how to do mixed methods research. And during that time at RTI, there's Dato and Irma from the Republic of Georgia. We got a 5-year R01, and we were able to set up the very first women-only treatment center in the Republic of Georgia using a research context. And I also got to meet Bronwyn Myers, and we did a R21 that we didn't find any statistically significant differences, by the way. And actually putting this talk together, I realized how many more times I failed than I actually have really good outcomes. Anyway, so South Africa, we were there, and we developed a short intervention for treating methamphetamine during pregnancy, and it was a wonderful experience that gave us great foundation for later work. So this very complicated slide is our entire MEDI projects, which was a mixed methods project, all in one slide. And so I learned at RTI how to have a community advisory board, how to use that, how to have a regional expert panel to get real buy-in from the community so that the research wasn't something that was done to you, it was done in the collaboration with you. And so we knew nothing about the women in the Republic of Georgia that were using substances. So we got to interview the entire population of substance-using women in treatment in Georgia, which it was an N of 6. Yeah. And so, but then we found out that there were more, they just weren't in treatment because treatment was a really scary place. And so we were able to take this work from our qualitative interviews and be able to have conversations with the drug treatment providers to make it more comfortable for women to be in treatment in the Republic of Georgia. And then we went on to develop from the mixed methods, or from the qualitative work, we were able to develop and design an intervention for women and then test that intervention. And so moving on now, so expanding the world even more is working in Afghanistan. And so we had in 2010, I had the very interesting call from Steve Gust at NIDA, and it goes kind of like this. Hey, Andre. Hi, Steve, how are you? Good. Hey, you want to go to Afghanistan? It's like, whoa. Yes, actually, I do want to go to Afghanistan. It's been someplace that I've always wanted to go. And we got to go. We got to go with the United Nations and with the State Department, and I got to learn so much from that experience. And we got to see the Women and Children's Center, and it is with Sabor Abdul Momand that we were able to develop and implement psychosocial protocols because they had really good infrastructure. They just didn't have the behavioral tools to be able to make meaningful differences in the lives of children to help them not use drugs. And so you can understand, children, when I say children, I mean children between the ages of 3 and 12 were actively using substances like opiates. So this was an opportunity to intervene. And so this is the collaboration. These are almost all the authors. I was missing one of the authors' pictures. I couldn't find it. So this is Sabor Abdul Momand and Beth Matfield from the UNODC, Brian Morales, and Tom Brown from INL. And we were able to get data on 689 children that went through. This is just a little pre-post, so there's no comparison group. It was an evaluation. It's not some kind of randomized trial. But it was enough to show that at least from treatment entry to treatment exit, and then in follow-up, that children were able to get better on a variety of domains. They were able to reduce their trauma symptoms. They were able to reduce or improve their quality of life. And so that allowed us the data that we needed to then go forward and develop a curriculum that's a 6-volume curriculum to train other people on how to do this work. And so we've trained people from India, from Bangladesh, and from Pakistan on how to work with children that have substance use disorders. And the sort of best piece of it is that little suitcase for life down there, which has got 8 different modules that are very child-friendly. And there's a whole way of talking with children and working with children as play and understanding their development. And then we adapted those protocols for Brazil. And then we have a whole training family down below where we've trained people in Chile and Paraguay and Brazil on how, and Peru, actually, to work with children. And so finally, with all of this data, there was a wonderful collaboration between INL and NIDA that funded the world's first randomized controlled trial on an intervention for working with children set in India. So now we're going to have boys and girls that are going through this, this project, and Sabor is in the United States working with me leading that project. But that's not enough. Right? So we can treat people. I treat people every day at Horizons. They get better when they leave, and then they come back because we don't have a recovery-oriented system of care. So we need to do a better job of understanding what recovery is and understanding what the key ingredients are for helping people stay well. And the same is true for children, because if we don't treat their families as we're treating the children, if the children have families that can be identified, our chances of being successful long-term are diminished. And so this sort of graphic is something that I've been thinking a lot about and how we can break that down. And so I really would like to see my next sort of set of studies really trying to do a better job understanding that. So going back to the pregnancy and opioid use, because it's been such a focus in the United States, I have 4 modest proposals for us to consider as we move forward. One is shifting our focus from prevention being a single point in time or very specific, discrete points in time, but being continuous, right? So I think this has been said before, prevention needs to be like sunscreen. You put it on every time before you go out, right? And so having a gendered approach, because we understand that there are differences of children initiating substance use between males and females. And so what can we do to better tailor our prevention to gender or to sex? Second, to really focus on the issues that are underlying women initiating or individuals initiating and maintaining their substance use disorder, their opioid use disorder. And until we start to address those real structural issues, the homelessness, the poverty, as a part of the complete equation, I think we're going to continue to see vulnerable women. Third, every single person that interacts with a woman of childbearing age needs to be trained about substance use and where to find help. And so I would include those who are in the law, those who are in justice, those who are in health, as well as social services. There's so many justice providers right now in the courts and police and first responders that really are hungry for this information about how to help people. And then finally, when it comes to women and children, we need national standardized approaches around when children should be removed and when they should be allowed to stay with their children. Because right now it's county dependent. I can tell you with almost 100% certainty which children are going to be removed and which ones aren't, based solely on the county that they live in. That is not a good thing. And so I'm going to end my talk with a few things. And its final thoughts, it comes back to the listening to women. And the women in the program, if you ask them, they'll say, please don't rush us. Please don't give us a 28-day program. Please don't even give us 9 months. We need more, because real recovery takes time to achieve. Please give us small women-only groups. Don't make me sit in a mixed group where my abuser might be on the other side talking. Please don't judge us. Believe me, when we walk into treatment, we have so much shame and stigma already, you can't make us feel any worse. Please give us empathy and real skills and real support. Teach me how I can go back to school. Teach me how I can get a job. Help me negotiate that job offer. Please be true to your word. If you make an appointment with me, keep it. Please let us be active partners in treatment so that treatment isn't something that's done to me. It's done in collaboration with me so I can feel in control, because ultimately I am in control of what I'm going to do. And help me be the best parent. Don't just tell me what to do, but show me how to be the best parent I can. And finally, give us residential services where I don't have to make the gut-wrenching decision of, do I get well or do I continue to care for my children? To end with some acknowledgments, I am eternally grateful for NIDA for your continuous funding of our research since 1994. I am very thankful for INL and for SAMHSA for all of the support and belief in our research. To the international community of UNODC, WHO, and the Colombo Plan for the women and the children who have participated in decades of research, to our many, many research assistants who have gone on to have amazing careers. It's been fun to watch. To our students and other learners that roll through, and I feel so good about training the next generation. And to our colleagues around the world and in Horizons, which that group pictures of Horizons, I thank you. And for the, I'm not done yet. I still have 7 minutes. And to the next generation, I have a few ideas. And so this was taken last year, you Breakfast of Champions people, you. Persevere. Bob Bolster told me the best quality I ever had was my perseverance. I never give up. Don't give up on your dream. Respond versus react to things. I've learned how, personally, I've had to learn that the hard way. I hope you don't have to. Be open to possibilities. Say yes to everything thing you can. And then when you get older, you have to learn how to say no, and I haven't learned that one yet. Be open to possibilities. Take feedback kindly and take it seriously. Those people that are older than you, they know what they're talking about. And finally and foremost, be kind. And this is the last slide. Most importantly, thank you to my family. It is amazing to walk in your wisdom, and I could never do it without you. And I know you've sacrificed a lot for me to be here today, and so thank you. Now. Thank you very, very much.
I'd just like to give Andre this plaque to acknowledge her, her contributions. Yeah.
Thank you. Thank you so much.
Thank you all.
Thank you.